Yes.
Go ahead. Oh, okay. Hi. We're group 6. We're going to be going over module two, the evaluation and individual treatment plan, and our fictional case study. I'm Annie.
And I'm Mandy. This is the purpose. This slide introduces the evaluation as a starting point of a counseling process. Evaluation is not just about identifying substance use. It is also about understanding the whole person. It helps to determine whether a substance use disorder is present, how severe it is, or what factors may increase risk, support recovery, and this information directly informs diagnosis and drives all treatment planning decisions. Here are the main components of a comprehensive evaluation. This includes such things as the client's personal information, physical and psychological conditions, and social functioning, as well as any co-occurring mental health conditions, whether the client has legal obligations or vocational needs. It also gives a history of substance use plus the strengths and support system and their motivation to change. This is the role of the counselor in the evaluation. The role of the counselor is to integrate clinical expertise and ethical practices, the use of screening and assessment tools, and it is the counselor's duty to keep an ongoing observation and help the client self-report ongoing status. It's a good idea to remember that the evaluation process is a continuous process, not just a one and done event. An individual treatment plan is developed collaboratively with the client and is based on the evaluation findings and the client's goals. The treatment plan includes measurable and achievable objectives. It addresses substance use and co-occurring needs and emphasizes client strengths and readiness for change. The importance of ongoing review and documentation is to have a regular monitoring of progress, and client outcomes to keep treatment plans updated as the client needs change. It helps encourage the client's engagement and accountability and supports long-term recovery and relapse prevention. And this is our case study.
So we built a case study around a male, 32 years old, Native American with the Navajo Nation, single co-parenting one child with middle to low income. He was referred to counseling and to be assessed by the emergency department following hospitalization related to peyote ingestion through dehydration. So let's see. He expressed that like he's only used peyote in his background. It used to be through the his ceremonial use within his culture and like religion. It shifted into more daily use following the death of his grandfather, separation, um, and yeah, dealing with emotional pain and stress. Here is the history of his presenting problem. I'm not going to exactly state everything, but you guys can reference it back, especially when you're going to be doing your discussions. But he started using peyote at 19, like we mentioned before, through cultural ceremonies. Due to a breakup and loss of employment, began using peyote privately. Grandfather had a really close relationship with his grandfather. He's reported increase in tolerance, missing work, financial strain, use like using a lot of time towards using peyote in his downtime or private time. And he no longer feels spiritual, but something that he's like impulsively having to do. Here's some of his more BPS social and family history, family substance use history. His father had alcohol use disorder and two cousins with methamphetamine use disorders. Um, he's been active in the community and ceremonial activities, though with the increased peyote use, he has withdrawn socially. Here's some spiritual and religious history. The client identifies as a lifelong member of the Native American Church, in which peyote is traditionally utilized as a sacramental medicine for prayer. As use progressed outside of traditional ceremonies, though, the client endorsed increasing spiritual conflict with feelings of guilt, shame, perceived disconnection from the creator and the NAC community. Um, Client was raised on the Navajo reservation by their mother and maternal grandparents. Client reported they were very close to their grandfather, strained relationship with their father. Just some key points. I don't want to read everything because it'll get very long because we got a lot to cover. Some of the psychometric screeners that we did for him was the Holmes Ray Stress Life Inventory, with a score of 230, indicating 50% chance of developing a stress-related health problem within the next 2 years. And then some of the symptoms or items that were selected within that screener are listed. The ASSIST, which is the alcohol, smoking, and substance involvement screening test. The client scored 2 for tobacco, really low. He did use tobacco ceremonially listed in his ASAM assessment, which is indicated here in this screener as well and validated, and then scored a 37 for hallucinogens, indicating really high risk of experiencing severe problems as a result of the current pattern. The RCQ-TV, the Readiness to Change questionnaire, he scored +4 on contemplation. He knows that has a problem. He can acknowledge that and is still kind of ambivalent in the action he's taking. The OQ-45, he scored fairly high, 84, with the clinical cutoff of 64 or higher, indicates significant distress. The questionnaire is to gauge the client's psychological stress and intensity of the symptoms that they're experiencing. And I noticed that there's like flag questions like 8, 32, 44, which indicate like different things, suicidal ideation, homicidal ideation, and suicidal ideation again. So 44 was the only one that was above 0. So even though it's above 0, it's still flagged. So even though he marked rarely in response to I feel angry enough at work or school to do something I might regret, it's still something to consider and may need further evaluation and assessment or like intervention. Here's the ASAM criteria. Dimension 1 was moderate, psychological dependence, prior emergency department visit. Dimension 2, the biomedical, mild, one medical incident, otherwise healthy, as reported. Dimension 3, emotional, behavioral, cognitive, was moderate, high distress, as indicated on the OQ at 84. Dimension 4 is moderate contemplation stage, as exhibited by spiritual conflict, but motivation for change. Dimension 5, relapse and continued use is severe, as they stated they cannot. They're using and seeking to use every day with strong cravings. Dimension 6, their recovery and living environment is moderate, supportive family, but the community engagement, cultural disconnection is there, as well as temporary job displacement as well. So the ASAM recommended level of care is 3.5 clinically managed high-intensity residential services. Here's our diagnoses and Z codes. So the F1620 hallucinogen disorder, specifically peyote or mescaline, which is severe. Client meets multiple criteria. Total was about 7 or 8 criteria out of the 11, though we only listed a few here that were like just key ones to point out. Taking in larger amounts, cravings, unsuccessful attempts to cut down, continued use despite harm, though peyote does not give you physical withdrawal, it is still psychological dependency coupled with the frequency duration is making it severe. The Z codes that contribute to his situation is the disruption of family by separation or divorce, disruption of family by death of a family member, acculturation difficulty, as discussed in the history of presenting problem, family, and spiritual background. Here's the treatment plan that we created. So we focused on the acceptance and commitment therapy. As you can see, we outlined 3 like long-term goals: the achievement and maintain abstinence from non-ceremonial peyote use, reduce emotional distress related to grief, shame, and spiritual conflict, strengthen recovery supports, and culturally grounded identity. Those are like umbrella goals. And then with each one, we go into depth on the how and then why these goals are important, as well as then in other treatment plans, you would also do what the interventionist is going to do, but we didn't include that in here. Um, like the interventionist would measure, like review with them their um, internal and external triggers, inventory, and see how they've been reporting on them to assess progress and things like that. But please, in your responses, please take a look at this, read it to help understand it a little bit better. With the acceptance and commitment therapy, we chose this because it's evidence-based practice. It supports emotional conflict, practices grief-related coping, and explore shame. And the skill that we chose was urge surfing. This one's a really easy concept, though it is very, what is it?
It's, I don't know how to explain it.
We just talked about it. It was like
Okay.
a metaphor,
Yeah,
metaphorical,
yeah,
I guess, which can be hard for some to
understand.
grasp. But this one can also be fairly literal, depending on how you present it to the client and what their understandings are. So you easily just identify a craving, as explained in the treatment goals, like write them down, um, their internal experiences, and recognizing that is important. It doesn't need to have an action. It was observing your physical, emotional um, feelings and thoughts without acting on them, sitting within that moment of distress, and then letting that distress subside over time because it will eventually go away. It's just being able to not act on it. Here is a really crappy visual of the urge surfing um, for reference. And then here's our questions. Please check them out to base your responses off of. How can clinicians differentiate between culturally sanctioned ceremonial substance use and substance use disorder? So like when a client's using it in ceremonial reasons, but when's that line broken, right? And turned into a substance use disorder? And how are we going to practice the identification of it while being culturally sensitive and ethical in our practices?
Mm-hmm.
What other cultural and ethical considerations could have been made for this client? How might unresolved grief and spiritual conflict complicate recovery planning? Like, did that treatment plan incorporate his cultural background? And what risks arise if these factors are not addressed in treatment? And then there's a couple of the references from the ACT that we chose. Yep. That is all.